What happened to July? Did the fellowship end early?
Yeah, it's a good question. The schedule we got actually ended here for all the topics.
Yeah, there's not any other topics we can possibly discuss in July.
That's right. So today's topic is spinal oncology, a very, very broad topic that I will go over. And the majority of the talk here is going to be identifying the most common types of pathology that we see affecting the spine, overall the characteristics, even some of the histopathology, which I really can't go into too much depth with, and then the treatment both non-operatively and the diagnostic workup, which is I think very important with certain tumors, and treatment both non-operative and operative. So if we look at the different types of definitions, spinal tumor in the most common baseline definition would be abnormal mass or tissue. And this can have or can be without any kind of spinal cord or neurologic compression. It can have different areas of the vertebral column that can be affected. In terms of location, it can affect the entire neuroaxis and have different implications in the location. And also can let us know what type of tumors have a predominance for certain areas of the spine, which we'll talk about. Within the anatomical location of the vertebral bodies and the spinal canal, it's important to understand what can be intradural, extramedullary, intradural, intramedullary, and what can be extradural. And we'll spend just a minute here looking at that. And so the two characteristic areas can be either extradural or intradural. And extradural lesions largely are metastatic. And we'll hit that point multiple times because metastatic spine tumors are the most common tumor that will affect the spinal column. The intradural tumors then can be categorized as intramedullary, and these will often have some type of signal intensity or attenuation within the spinal cord. And the extramedullary lesions are located within the dural sac, but exterior to the spinal cord. And so on MRI, those intramedullary, extramedullary tumors are not going to have the same signal intensity on MRI within the spinal cord. And then another differentiating factor can be the aggressiveness of the tumor, just like we see in the appendicular skeleton as well, is benign and malignant tumors. And so those, some of those we see in other areas of musculoskeletal oncology. Those can affect the spine as well. Osteochondromas, osteoblastomas, aneurysmal bone cysts, giant cells, which are categorized as a benign tumor. However, the giant cell can be very locally aggressive. They can also affect the lungs and have implications for surgical treatment, and the recurrence rate is often high, as well as they do have a very, very small chance, but real chance of having conversion to a malignant type of giant cell carcinoma. A hemangioma can also affect the spine, and actually we see this incidentally very often within the vertebral bodies. So this is not something that is totally irrelevant in the spine, and actually can have implications in surgical management when it's not known or not diagnosed prior, and certainly area of bleeding within the bone can be very worrisome depending on which area of the spine you're operating in. Eosinophilic granuloma, also called Hanschüler Christian disease, is another benign form of tumor that is commonly seen. And then the malignant tumors, osteosarcoma, primary bone tumors, Ewing, chondroma, and chondrosarcoma can be seen also. Multiple myeloma and lymphoma can also affect the spine. So when we talk about intradural extramedullary tumors, accounts for 60 to 70% of all the primary spinal cord tumors. And usually the patients, because of the location of these tumors, will present with some amount of neurologic compression, whether that is central cord compression. Depending on the location, patients can be myopathic or profoundly weak very quickly because the certain threshold for the canal, the capacity is compromised with the tumor growth or tumor mass effect, or they could have radicular symptoms. The red flag symptoms that we always talk about with patients are very important to discuss with patients here. Pain that wakes them up from night, other systemic types of symptoms, including fevers and chills, appetite loss, and weight loss as well. Cauda-equina-like symptoms can happen if it's a tumor that affects the lower spinal segments. And the most common types of intradural extramedullary are schwannoma, meningiomas, neurofibromas, paragangliomas, and ependymomas. And now we'll go into a little bit more depth on these five after we talk about the intramedullary types of tumors. We'll move on to the extramedullary. So typically within the spinal cord, and the other ones that are associated are the astrocytomas. So schwannomas are peak incidence usually of 40 to 50-year-olds. Most of them are benign. However, there is a smaller subset that can be malignant or have aggressive features. We do see a pretty dispersed pattern of where they're going to be in the cervical and thoracic spine largely. Very few of them are at the conus or lumbar spine, as the spinal cord ends at that lower thoracic, upper lumbar area. Most of them are within the area of the spinal cord itself. Most are solitary and sporadic, and actually on this MR, it's a little bit washed out, but at the lower thoracic area, you can appreciate that there is a central large lesion that is largely homogeneous in its finding on the MR, and it doesn't have a lot of heterogeneity, which is a T1 isointense, and on T2 it'll be hyperintense. Looking at the histology, it does have Antoni A hypercellular and B hypocellular pattern, which is pathognomonic for nerve tissue, elongated nerve cells with significant collagen background, and the stain is positive for S100. Differential here can be neurofibromas, meningiomas, and paragangliomas, all nerve tumors, and so the location is also very obvious as well for these types of tumors where they're intramedullary, intradural, because of the type of tissue it's around. To make sense, the differential is very similar here. Surgical resection is usually the treatment here because of the amount of neurologic compression that these tumors can have. A gross total resection is usually actually curative for this, and the recurrence rate is relatively low unless the patient has neurofibromatosis type 2, which has a high incidence of regeneration of that nerve tumor tissue. These are representative x-rays, which don't seem all too concerning. However, if we really pay attention at the lower, maybe T10 area around the pedicle, there seems like there is some type of effect of a lytic area around the pedicle region. And on a CT, right around that level, you can actually appreciate that much more clearly. And so there is a very large type of lytic lesion there. And so It's important to notice on X-ray, those findings can be very, very subtle, but certainly it is there if we take a look. We've gone to meningiomas, 25% of all spinal cord tumors, and often occur in women. The thoracic spine is more common here. The incidence of age is usually 50 to 60-year-olds, and the risk factors for this can be neurofibromatosis type 1, or a genetic history of neurofibromatosis type 1, or type 2, I'm sorry, and a history of radiation. On the MRI, we'll find that this is also well circumcised, homogeneous in nature, and its characteristic MRI findings, and dural based. The histology of meningiomas, different in the sense that they're lobulated architecture, and does contain meningothelial whorls. So you can see the swirling on the right on that histology slide. So if symptomatic, the surgical resection is the largely curative treatment for meningiomas. And if there is recurrence, then we do consider radiation for these types of tumors. However, if they're asymptomatic without any significant mass effect, these can be watched, as some of these can be pretty slow growing. Now, moving on to neurofibromatosis and neurofibromas, these are also benign nerve sheath tumors, and they arise in non-myelinating Schwann cells of biliac inactivity, with biliac inactivity of NF1 tumor suppressor gene. So it's actually a loss of this expression of the protein neurofibromin, which is characteristic of these types of tumors. There are subtypes, both the dermal, which arise from single nerve, peripheral nerves, and plexiform, which arise from multiple nerve bundles, pathognomonic specifically for NF type 1. And so diagnosis of neurofibromatosis, you have to have 2 of 7 characteristic criteria, 2 or more neurofibromas, or 1 plexiform neurofibroma, the larger conglomeration of neurofibromas, axillary groin freckling or crow's sign, 6 or more California Calafeo lay spots, 5 millimeter in younger patients, and more than 15 millimeters in adult patients. Sphenoid wing dysplasia or thinning of the long bone cortex. These patients in their adolescence in their infancy will also have anterior lateral tibial bowing, which is pathognomonic for neurofibromatosis. 2 or more Lisch nodules or iris hamartomas, optic gliomas, and also usually they have a very high predominance with a first degree relative with neurofibromatosis type 1. And so if these are symptomatic, usually it depends on the location, but radicular sensory changes can be along the dorsal sensory roots. Multiple lesions in this areas can cause multiple different radiculopathies, and those patients will present with almost a non-dermatomal distribution because of these multiple radiculopathies overlaying with more of a global picture. And then if really they have significant effect, like this characteristic MR, you can see that the lesion is very large with significant cervical spinal cord compression. The patient can be fluidly myopathic as well. Most frequently, they do occur in the cervical spine, these neurofibromas and neurofibromatosis patients. Largely, however, they are slow growing and remodel with the adjacent bone. So they have widening of the exiting neuroforamen at these levels. And because they're slow growing, surgery is the treatment of choice overall. However, you have to really tease out the nerve roots as they become totally encased. Some of them do have a chance to have malignant transformation, which is rare, but can happen depending on the genetic disposition of the neurofibromatosis. Ependymomas are the most common primary intradural intramedullary primary tumor, and they originate from ependymal cells aligning within the ventricles, central canal of the spinal cord, and cells that rest along the film terminale. And so we can see these within the intramedullary portion as its characteristic. It'll have this tail that you can see on the MRI, both going up and down. It's a little bit heterogeneous in its nature and signal intensity as well. The majority of these are benign, and some of them, the anaplastic ones, can be malignant. However, that is overall pretty rare. And this is the characteristic histopath, which has perivascular pseudorosettes. Most of these are also slow growing, as it's a nerve tissue tumor. However, because of its area in the cervical spine that it usually affects, it can have significant spinal cord compression. However, will not infiltrate into that. And so if we do have surgical management for this, it becomes a little bit easier than some of the other tumors to tease off rather than having a tumor that totally encases nerves and having to peel that off. Another type of ependymoma is the Mixo Papillary. This is exclusive for its location within the spine and actually only occurs in the filum terminale or at the conus level. And this has a earlier predominance in age, around 35 years old. Also slow growing tumor, and the treatment is the same because it doesn't encase the nerves and is able to be totally excised. It's largely a curative surgery. Astrocytomas also are seen in patients that are usually in their 30s. It can happen in children as well, and it's the most common intramedullary tumor of children, 80 to 90% of those. However, the mean age is still around 29 years old when they present. It's typically located eccentrically within the cord, and most commonly it's in the thoracic region. And it may be exophytic, and it may appear to be extramedullary because of its eccentric nature. And it does have peri-tumor edema, which you can note a little bit on this mid-sagittal MRI. They tend to be a little bit more infiltrative than ependymomas and have increasing morbidity from that in terms of the treatment with surgery as well as the success rate from surgery, because there is usually some amount of tumor burden that is non-resectable because it's encased. And so that differentiates it in its overall outcomes compared to ependymomas. There also are faster growing. And so because total resection can be a little bit more difficult compared to the other intramedullary tumors, radiation is used as well as chemotherapy in some patients post-operatively. Extradural tumors now we'll move on to, and these, the most common is going to be metastatic spinal cord tumors. Vast majority of these will be in the vertebral bodies, and the representative of the advanced systemic disease of these patients. We can also have drop mets from cranial lesions, and that can potentially be from brain metastatic tumors that will seed through the cerebrospinal fluid itself. Mets will rarely be intramedullary, and it's less than 1%, but really those are exceptionally rare. The MRI is rapidly expanding usually and progressive, and the surgical resection also in terms of these tumors is overall pretty rare. It's tumor control with radiation and chemotherapy. And if there is mechanical instability, surgical stabilization for fractures is certainly done to provide the patient more structural support. So multiple myeloma, one of the most common types of tumors seen with involvement in the spine itself, is usually seen, it's a proliferation of plasma cells seen more than 40, usually mid to older age, predominance for males and African Americans. Diagnosis requires one major and one minor criteria, or three minor criteria. Major criteria would be confirmation with a biopsy, more than 30% plasma cells on the biopsy, serum IgG of more than 3.5, IgA more than 2, and then also the urine IgA of more than 1, or Benz-Jones proteins. So those diagnostic features are what we typically will order for these patients as they're undergoing a workup. The minor criteria are 10 to 30% plasma cells, presence of punched out multiple lytic lesions, and patients on these skeletal surveys, you will see them spanning from their calvaria all the way down to their appendicular skeleton. Decreased serum IgG levels are also one of the minor criteria. And so the workup has to be complete here with a workup for anemia, the creatinine. There's hypercalcemia in these due to the excess bone resorption with these punched out lesions, elevated ESR, SPEP, and UPEP. And the Benz-Jones proteins are pathognomonic for that. Mainstay is, for most patients with multiple myeloma, multi-agent chemotherapy. And these are cytotoxic agents, a little bit older generation chemotherapy, but given, with steroid. The surgical stabilization and for complete and impending fractures is something that is performed in patients that have lost the structural support, or if the patient has undergone radiation without significant improvement of the lesion and continued pain, that may be an option, as well as kyphoplasty if it's a painful fracture. A chordoma is a malignant type of tumor with primitive notochordal origin. It's very slow growing and commonly misdiagnosed with only back pain. It's the most common malignant spinal tumor in adults. However, it's not aggressive as it is very slow growing. And so METs do occur with this, 30 to 50%. And overall, the 5-year survival is 50%. The treatment is a surgical wide margin resection with or without the use of radiation afterwards. For this type of surgery, it is common to have to sacrifice sacral nerve roots to achieve the appropriate margins. And if those margins cannot be achieved, those patients will typically have post-operative adjunct radiation. Now we'll switch gears just a little bit, and now that we've gone over kind of the majority of the types of tumors that we do see affecting the spine, I thought that it would be useful potentially to look at the two types of classifications that have guided some of the treatment in the treatment of the spinal tumors. So the Anakin Classification came around the 1980s, and it was a modification of the Anakin Classification for the appendicular musculoskeletal tumors. And the tumors were staged based on biologic aggressiveness, anatomic extent, and the presence of the METs. And it was meant to predict the prognosis and also guide the choice of surgical margins in patients of primary tumors in the extremities. However, when it was adopted into the spine tumor pathologies, it wasn't totally able to be as prognostically predictive or guide treatment as well, because it doesn't account for any of the continuous epidural compartment, as well as neurologic implications of sacrificing different spinal cord nerve and roots, or the need to really look at spinal instability. And so because of these features, this Anakin stage um, of tumor classification was built upon with the Weinstein-Barani Biagiani classification, which divides the stage of spinal tumor with its unique complexity specific for the spine. And this was meant to provide more of a surgical planning and resection guidance without compromising any surgical tumor margin if possible, and causing the least amount of injury to their neurologic structures. And so these are basically the two that are most commonly used in terms of surgical planning based on either the aggressiveness of the biology like the Anakin or the location of the tumor as well. And so I thought we'd finish looking at some of the different classifications, the recommendations from the Spinal Oncology study group that has worked with the AO and looked at the different recommendations. And this is a focus article from just a few years ago looking at different tumor pathologies and what the recommendations are currently in their treatment. What we'll notice as we kind of go through this is that although some of the strength of recommendations from the different literature that exists is potentially moderate to strong, which would be at best, the quality of all of this evidence is so low, given, number one, the rarity of primary tumors of the spine, and secondly, the metastatic patients that have the most often spine pathology have such a difference in systemic burden that it's very difficult to study those patients. So if we start off with benign tumors of the spine and what the treatment says for giant cell tumor, there is a role for denosumab, which is an immunologic medication used in the appendicular skeleton, and that is largely for inoperable giant cell tumor, as well as for a neoadjuvant type of therapy. And this is a drug that has changed the management of giant cell tumor in the appendicular skeleton, but for the axial skeleton spine, it also seems to have a significant amount of effect. There is also a propensity to look at what the role would be for denosumab in the treatment of aneurysmal bone cysts. However, it does not seem like it is a first-line agent when we look at those. When looking at safety and local control of radiation therapy for chordomas, there is a role for patients that are undergoing surgical management for chordomas and de novo chordomas. When surgical margins are concerning, they should have postoperative radiation. And there is a significant amount of toxicity for patients undergoing that type of radiation treatment. However, the overall recommendation for use of high dose radiation is not extremely strong when the local control rates are low with surgery. So if there is incomplete resection, radiation may be used. However, the success rate is probably a little bit unknown. Wide en-bloc resection is the primary treatment modality for chordomas, if possible. And for areas that we cannot do that, in terms of recurrence, there's also strong recommendation for using radiation in those patients. Looking at soft tissue and bone defect management in patients with total sacrectomies, which is a very rare surgery, but performed for primary sacral tumors, there should be spinopelvic reconstruction for those patients, and some of the largest work for sacral reconstruction is in primary sacral tumors that have to be removed in its entirety, and a lot of those are chordomas. Looking at some of the consensus of expert opinion on best reconstructive options for on-block spinal column tumor resection, anterior cage is recommended with anterior column support, which makes sense. But even then, the literature is very low just because these series are so small with single center studies. And in most patients, we should optimize the adverse event profile. And so they do recommend that primary spinal surgery should be performed basically at experienced centers. And for the majority of spine tumors, because they are metastatic, a lot of those will be seen within the community. Primary bone tumors should be referred over to spine oncology centers. Looking at metastatic spine tumors, predicting the recovery with patients with spinal cord compression and neurologic impairment, a patient who is experiencing a neurologic deficit resulting in any loss of ambulation without the absence of undergoing surgical decompression should have prompt surgery to relieve that. And so that really is the guiding point that has led surgical management of spinal tumors, is whether there is involvement of neurologic impairment and compression. Radiation therapy should be involved with adherence, especially if the patient has a radiosensitive tumor burden. However, that is largely a oncology-based treatment modality in multidisciplinary rounds. And one of the more recent things that was looked at in this focus issue and guidelines is whether minimally invasive techniques would be possible. And they did find that with a small amount of retrospective literature that exists, it does seem to be not only safe but effective in decompression of focal areas where you're not necessarily looking for an on-block resection of the spine. And certainly we've done that not only here with decompressions, but also instrumentation of and stabilization of spinal tumor. In terms of the evidence that exists at this time for reconstruction, it really still is based on life expectancy and performance and functional status of the patient, and whether there should be bone graft or not is one of the main questions. And there is literature to support the use of bone graft in spinal pathology, especially as it is pathologic bone and probably needs help. However, BMP is not going to be ever used, obviously, in the tumor setting. And so that's one thing we obviously will not see. The overall optimal construction and reconstruction techniques, basically all the literature says that anterior and posterior column reconstruction is advantageous, as the bone is largely not going to heal or have significance for recurrence, especially when stabilization is performed without any kind of resection. And there is strong evidence also to support any decrease in reduction of revision rates, especially when it's related to the soft tissue reconstruction and the timing of radiation after a surgical treatment is very important in these patients. And so delaying that until total healing of the wound at 2 to 3 weeks time is usually ideal. And we'll do this in conjunction with the plastic surgeons as well as the oncologists for these patients. So large talk with a lot of information, and I thought I'd leave basically with this slide as a summary because I do think that knowing the location of the tumor and the types of tumors that exist in those locations is the workhorse of understanding what you're dealing with and potential treatment algorithms. So I will stop there, and if there's any questions, I'd be happy to take them.
So thank you. I mean, once again, like you said, a lot of these tumors, I mean, we have the most experience, as you all know, with metastatic disease, right? That's what we intradural tumors we send off to the neurosurgeons to deal with. And I think the take-home messages are that the most common things that we see are probably intramedullary or the ependymomas, and extramedullary are the meningiomas and the schwannomas, right? And I think one of the key issues, we see often a lot of schwannomas, right, in patients that are asymptomatic. And they may not, and they come in because we think they have degenerative problems and they're very concerned about the schwannoma. And I think one of the key issues in the history when you try and deconstruct it with the patients are that when a patient has a schwannoma, and maybe they have some radicular symptoms in their neck or low back even, that they need to be followed, because the fact that they're having increasing neurologic symptoms probably means that the schwannoma is growing, right? It's getting larger. And probably that's a sign that it needs to be excised. And often it's difficult to really measure the size unless it's absolutely obvious, right? So I think that's a key thing that you need to decipher in the patient's history. I follow a bunch of people with schwannomas, and they usually come in and they're asymptomatic, and I say, well, let's see you back in 3 months. We get a repeat MRI, see how you're doing. You counsel them. Most of them can be treated conservatively, as the schwannomas, but the ones that grow are worrisome for increasing symptoms and need to be excised. Any thoughts on that?
Overall, it seems like because it's such a high lumbar incidence of schwannomas also, and the radicular type of symptoms they present with, there are also such high rate of misdiagnosis and totally missing, even when they see spine specialists, actually. That's one of the interesting things that I found about even diagnosis of schwannomas.
The only other comment, real quick, and you sort of brought this up on best practices with the spine issue. That I'm glad you read through that spine issue. I mean, it's an unbelievable resource of sort of evidence-based expert opinion, an expert opinion on tumors. But as you know, we usually use the plastic surgeons when somebody's been irradiated or they have recurrence. And I think it's important, as you guys go off, to think about the soft tissue healing in these patients, especially if they come back with a complication, wound problem, or revision that requires resection, to get them involved to help take some of the tension off the muscles, right?
I would say even our post tumor radiation complication profile has been so low overall, because we work with plastic surgery for the most part that I've seen over the past year.
Any other thoughts or comments? Dan, Eugene?
Yeah, I'm driving in the car, but I thought that was an excellent talk. So really, really well put together. And I really have very little to add. other than, we see Mets much more than we see anything else. So really understanding the management of metastatic disease is the thing you need to concentrate on. And the thing that they always teach us at the courses about metastatic disease is the most important thing to know is what's the primary, because that's going to determine the patient's overall prognosis more than anything else. So, getting that knowledge of what is the primary before you do anything else is key.
Yeah,
so it's Gene.
Yep, go ahead, Gene.
An excellent talking, very complex topic. One thing that I'll send out to the fellows is on maintenance of certification. There was an article about looking at these different classifications and prognosis. It's actually a pretty good article on which ones are good prognostic factors for longevity and survival of the patients. So I'll send that out to you guys. But great talk, so very complex topic.
Last thing I think you should take away is, and you sort of didn't touch, you had it in the in the best practices slide, but didn't touch on it, is the fact of something called performance status, right, or fragility index for patients. It's sort of analogous to the fragility index for patients, but looking how well patients are functioning when they're diagnosed with their tumor, is predictive of how well they would do with a surgical solution. So I think you can apply that for metastatic issues, obviously, as well as primary. So having an understanding, I would go back and look at the articles on how you can compute performance status. It's essentially just a gestalt of looking at somebody and seeing how healthy they look, right? It could be any one of us, God forbid, with a tumor, and we're all functioning, we're walking, right? We seem to be all doing well, and God forbid we have, this horrible tumor, and, hopefully because of our performance status and we look really good, that portends a better prognosis, right? It sort of gives you the liberty of offering that patient a surgical resection as opposed to somebody with metastatic disease or some other primary tumor of the spine that is bedridden, that's neurologically impaired, that can't get up and walk, right? That's just cachectic, malnourished, right? That's somebody that probably needs hospice, right? And doesn't need surgery. Any other thoughts? All right, so.
All right.
Thank you. Spectacular job.
Thanks so much. Have a good day, everyone.
We'll see everybody in a little bit.